So you mixed it up today. Now that's EJ over there. So that's a good joke, EJ. I gotta tell you.
Oh, you should put it
That's a
right
good
with
joke. You got me twice now. First you got me on EJ, the other night. All right. That's, we assume that you think that we're working with conventional procedures, and that's one of the things that sort of is one of the advantages of standardizing and having standardized procedures. But yet you see, for some of the things that you're going to do, that there is some variability. And here's kind of a funny thing. When we make the move to objective tests, physiological, electrophysiological tests, do you suspect we're going to have the same problem? That there's going to be a great variability of procedure and examiner input in terms of how to do it?
No.
Yeah, you're mostly right. You're mostly right. But when it comes down to it, there's still going to be some subjective judgments of the data that you as the examiner, now I will agree with you that there's going to be probably when you go into certain clinics and you're going to do ABR testing, there should be pretty much, and you're going to spend like a whole semester. That's what the students are slogging through right now in Dr. Suresh's first semester class. They're slogging through doing all of the measurements of ABR and changing the different parameters and such. And at one point, the clinic has to kind of agree, here's the parameters that we're going to use on all of our patients, and there'll be one set of parameters for adult, one set of parameters for children, and so on. So there'll be slightly variations. So that will be true, but the other thing is going to be that when you actually look at those data to analyze them, that's where it becomes subjective. So the paradox is that objective testing ultimately becomes subjective testing, even though a lot of this kind of stuff about exactly procedurally what are you doing seems to be much more well organized in the physiologic tests than are here. All right, so good. So good. That's challenge number one. Next one here, a true statement or not. Monosyllabic word recognition testing done at a level that's supra-threshold, whatever that may be. Can we get that information from an audiogram? In other words, is this a true statement? It cannot be obtained nor inferred from an audiogram. But does somebody want to correct that sentence to make it a correct sentence? And as you're looking at that, I'm gonna give you a big, not gonna help you cheat, but think about this. I gave this to you yesterday, to everybody except me, Zell. Yesterday, Tuesday.
You can have a good estimation if you use the calculator.
All right, so yes, so the fact is, you really should be able to infer what you're going to get based on audiometrically. You should be able to, based on that, based on audibility alone. But the reality is, you can't just take that number from the SII and just say, okay, the SII is 82, so we're going to put that over here in this space that says word recognition. You can't do that.
But if there was an instance when we can't conduct a word recognition test, what we need to provide some type of...
If EJ's question is, what if you can't do that? Can you just, you'd have to put in cannot test.
Yeah, and then you would say, but we can deduce it.
Then maybe in a discussion point you could say based on audibility. And what would that condition be, by the way?
If there's like either a language barrier, the child just can't repeat the words. If there's like a barrier where they can't.
Yeah, it becomes tricky because there's a number of things that might be at play. So let's think about this. Then if we're looking at an audiogram and we have a measure of audibility on the audiogram, and you're well acquainted with the SII and contributions of frequency to intelligibility, to the percent correct score that a person would get on SII, then what would be the main variables that would reduce that score, that would change that score? In other words, why can't we just use this? Why not? Should we start? Hi. Why can't we just use this as our measure of intelligibility? When we start to talk about the testing, you're going to see that there's either both major assumptions that are not supported in the testing that we're going to do, and or there's some variability. So in a way, word recognition testing is kind of a weird test to do. I like it. I think it's important. I think it has great face value. But I think what we think it's doing and what we're actually getting from it, there's a big gap in that sense. All right, so answer my question. So if we've got, if we have a good sense of how audiometric sensitivity contributes to the ability to receive, recognize, and again, operationally understand speech, not like the SLP would measure understand speech or the neuropsychologist would measure, auditory comprehension, but in our little limited, small peripheral systems way of thinking of stuff, what changes? What's the factor that is the main thing that somebody you're testing, given a flat audiogram, give me some ink. Now, given this audiogram, whatever 50 dB, and it's sensory neural, what factor, what's that person's word recognition score? It's going to be tested, assuming you're testing it correctly, so you're testing at a super threshold level. So again, your responsibility, I would say to you, the main thing that you got to do when you're doing this word recognition testing is you've got to cover audibility. You got to make sure that the signal that you're presenting, the speech signals you're presenting, are audible to the listener at a level that is going to help that is going to be at that maximum level. So what do we say that is? Generally said, it's going to be somewhere in the region of 30 dB, 40 dB above their threshold in the most important frequency region, which is what? The region around 2,000 hertz. So the rule that I've always used in my lifetime, and then one of the audiologists at San Diego State published a paper actually on it, so showing you that like minds do exist at some point, basically has a 2K, looking at 2,000 hertz and then making your presentation level dependent on what the threshold at 2,000 hertz is. The logic is right on that sheet in front of you, which is 2,000 hertz is the major contributor to the ability to understand words on these tests, okay? And really, to most of the sounds in the language, I guess. So that's where we want to maximize their audibility. So assuming you do that, what's the score? So assuming you're testing them, if this is 2,000 hertz, assuming you're testing them at 80 dB, 85 dB, so 30 dB SL, meaning SL, the reference of this particular threshold, let's say that's 50. 30 dB SL rate, 2K, threshold, pure tones, be an 80 dB HL presentation. What's their score going to be? What could it be? It could be 100? Okay.
Could be worse.
Could be worse. Could it be 0?
Depends
Well, depends on what.
how they acted before the testing began, and were they able to follow the instructions.
Okay, so let's assume it's a valid test. Let's assume that the procedures are all correct. Let's assume that you have a motivated person and that there's no other indices of non-organicity. So let's assume all of that's ruled out. So assume in all of the intents and purposes it's a clean test. That might be a reason why you might get a 0% correct score in some cases, yeah. So I'm not gonna, I think, Annalise, I think the point is, yeah, if you're reading a bunch of words to somebody and they just go, no, don't get it, nope. What does it sound like to you? That kind of stuff, you'll get them. One guy again, when I was at the VA, I'd say, I always use carrier phrase. Say the word dog, say the word man, say the word boy, say the word car, say the word yard. Those are, by the way, W-22 words. And the guy just started saying, I don't know why, Sugarfoot man, Sugarfoot dog, Sugarfoot yard, Sugarfoot. She's like what? Sugarfoot? What do you say? Like stop. They just had to stop and say that. Say, okay, I'm going to say, and it's really awkward when you actually talk to a civilian and say, I'm going to say the phrase, say the word. And after the word, I'm going to say a word, and you have to say the word that I just said. And I could just see, it's just like, this is like, who knows, some combat veteran, who knows what other problems they have in life. And so at some point, you're might have to abandon the carrier phrase or make some modification. So it's okay if you had to do that, but now you're just jumping in. And the whole point of the carrier phrase with the monosyllabic word test is so that your voice is kind of modulated, so like it's like a warm-up. And you got your voice, and then whatever VU or whatever indicator you're looking at, whether it's a light or a meter or a needle or whatever it is exactly at the 0 line on your meter. That means that 0 means that whatever you're set on your dial is, that's what you're delivering. If it's lower than that or more than that, then you're delivering not 80, you're delivering 70, or you're delivering 85. And so again, it just introduces variability to the procedure. So if you have to, you can say just the phrase, "Oh man," But I was always comfortable just to say the word. But when you have to explain to somebody, it doesn't work out. And when they don't understand, you don't have to say the whole thing. That's kind of goofy too. So. All right. So we said could be 100, could be poorer, could it be 0? Maybe. Okay. So what changes it from 0 to reduced to maybe 0?
Is that like when we think about the rollover, so the more you turn it up,
Well, what's the underlying condition?
Retrocochlear.
Well,
The patient.
fundamentally, yeah. So in other words, if we think about what's in the fact that we have parts of our auditory system, and I'm just going to put retro here. Which of these 4 contribute to that score, assuming you're testing it at audibility? Assuming you're testing at 40 dB SL Ray 2K or 40 dB SL Ray SRT, if it's a flat audiogram, because it'll be the same thing. Which of those 4 components are contributing? Which one or more components are contributing to that score? Retro for sure, and inner ear. So cochlear processing and then retrocochlear transmission are going to be the 2 locations in the peripheral auditory system where deficits may occur that you will see on word recognition testing. So another way of saying that is, if somebody has a conductive hearing loss, a purely conductive hearing loss, we would expect this score to be 100%. And if it's not, something's wrong. Okay? And if it's not, then you got to check on your audibility to make sure you're presenting it at an audible level. Because there's nothing about the conductive system other than providing adequate amplitude to the inner ear. There's nothing else that influences word understanding. So normal hearing should be great. Conductive pathology, doesn't matter what the degree of hearing loss is. That's why you got audiometers, and that's why they're plugged into the wall with power. You can crank it up. They should be able to hear it too. All right, so the problem then comes in is when we have this stupid word sensory neural. Are there cochlear problems that could create a spectrum of different scores here? Yeah. Are there retrocochlear problems also that could give us a range of scores from 0 to 100? Yeah. Remember I told you that if we're testing somebody with a pure retrocochlear pathology, middle-aged adult who has vestibular schwannoma or other kind of tumor, that's going to be growing and is going to be progressively bigger and bigger, and it's going to be causing over time increased compression. And most of what we call vestibular schwannoma is coming from one of the vestibular branches of the 8th cranial nerve on that side, and it's pressing against the cochlear branch of the 8th nerve, in which the higher frequencies are on the outside, the lower frequencies are in the core, so it's tonotopically organized. So as that tumor on the adjacent nerve gets bigger, it causes increased amount of compression and therefore dysfunction of the auditory nerve, of the cochlear branch of the auditory nerve. So in one person, over time, their ear could go from 100% to 0%. It really just kind of depends. I've mentioned to you before also, if we think about someone with presbycusis, that if you think about presbycusis, there might be 4 or more, or multiple and dual, triple causes of degeneration or dysfunction in their auditory system. That's going to cause their word recognition score to be poor. Probably not in their outer and middle ears. If the outer ear is open, arthritis is a big problem that affects adults. But we've never seen clinical arthritis or even rheumatoid arthritis or autoimmune versions of arthritis affect the middle ear. affects the inner ear somehow, and the bone and stuff in the middle ear, but it doesn't affect it like, you don't have reduced ossicular joint mobility. Remember, both the incus and really the stapes, the incus to the stapes joint is the smallest moving joint in the body. So you'd think, wow, if somebody's got arthritis, they would likely have a conductive component associated with that. And I've never seen any literature that supports that. And it seems counterintuitive. It seems like we just haven't found it yet, or it seems that whatever effect there is so washed over by whatever's happening in the cochlea and downstream. So again, point here being is that the inference just based on the audiogram, it cannot be inferred from the audiogram in the case of sensorineural hearing loss. So we could really amend this statement and make it a little bit more specific for you. So, can you infer it from an audiogram? Truly, yeah, if it's normal or conductive. But you can't if it has any degree of cochlear involvement. And so again, this audiogram here could be, literally, if this was like a praxis exam question, what would you predict that word recognition score would be? It'd almost be an unfair question. I need to know more about it. Well, what are the patient's presenting complaints? You just showing me the left ear. Is this bilateral? What other symptoms do they have? What's their age? So you really can't do that. As you add in some of those other things, then you will get a better sense of it. But again, if that would be an unlikely loss for a presbycusis. But if you gave me, this loss, and that's a 75-year-old, I don't know what that word recognition score is going to be. Is it going to be 100%? Probably not. I wouldn't go that far. But it could be pretty good. But could it be really abysmally poor? Could it be very poor? Yeah. And if that was the case in this year and the person had no other symptoms, my assumption would be, which would never be able to be proven, would be that their presbycusis is primarily due to neural components being the most advanced degeneration in their auditory system. But it's also possible that this is an ear that would have very good word recognition. I'll give again the other one that's kind of the paradox here is that flat loss that I put on here, flat loss or slightly rising. Again, when we think about audibility and you're presenting it at 40 dB, you're covering audibility. Is it possible that that's an ear that has very, very poor word recognition? Or would you always assume, flat loss, no, that should be pretty good? What's your sense? No. And again, the most common patient that you're going to see that's going to have either a rising or flat loss like this, and in fact, the sensorineural, we were talking about sensorineural, is, I'm putting on the wrong side, you guys aren't even correcting me. Polite. So sensorineural would be Meniere's disease. So a person with Meniere syndrome, Meniere's disease, is going to have a cochlear compression, so the mechanical system is just basically being immobilized by the excess fluid that's present in their scala media. And that will then characteristically give someone with Meniere's disease during the times when they're having their endolymphatic hydropic attack of having very poor word recognition. So there you have that. All right, so when we think about just some of the features that are going on here, that this test, this word recognition test, is stated to be a test of the person's ability to understand speech. So that's a broadly accepted statement that is highly flawed, but that's what everybody thinks. So if you go, again, it's like, what do your preceptors think? And they say, well, what are you finding out on the word recognition test? Well, it's a test of the patient's word understanding. That's a good enough answer. If you start to peel it back a little bit, it really kind of falls apart, because we'd have to, understand. We'd have to have a better operational sense about, well, what are we really doing here? What's the nature of our stimulus, and a bunch of other things. But as a general phrase, probably okay. If you're talking to people who, even audiologists who aren't very sophisticated, you're going to be very sophisticated operators. So you have to give everybody else, you have to cut them a little slack, okay? Because of your level of sophistication, you got to be gentle with them, okay? And don't bully them around or anything like that. So just okay. Use a standard list of monosyllabic words that are not familiarized ahead of time. Probably the most common ones you're going to be using is NU6. You may be seeing W22s. Essentially, NU6 words derived from the W22 word list, but basically reconstructed or ensured that the words were always in a consonant vowel nucleus consonant structure, which was not found in the W22s. I don't know if these are a word, but even like the word thin, consonant, vowel, consonant, like some of those. Dog, same thing. I'm trying to think of some. Anytime if you have, like on the W22 word list, you have any kind of consonant blends. I think on the word, I think this is a word on the W22, Lord. And so you've got consonant, vowel, consonant, consonant. So you've got maybe some consonant blends at the fronts of words. So the linguists out there in the mid-1950s criticized the W22 and said it'd be better to have a consistent structure of words with this, which is the C consonant vowel nucleus. All right, so these lists have the operational assumptions of what's called phonemic balance. Remember we said there was PB. What do we say we're looking for on all this? PB max. So the PB stands for, stood initially for phonetic balance, but then the same people that said you got to clean up these to make it that basically also said, well, it's not phonetic balance because phonetic has to do with individual acoustic sounds, which have nothing to do with linguistic meaning. But phonemes are acoustic sounds that convey changes in meaning in words. And so really we're not talking about phonetic differences, we're talking about phonemic differences. Okay, thank you for that. But here's the assumption. The assumptions are that these lists have phonemic balance, whatever that is. And these lists are representative of typical speech. If you think about it, that's what we want to try to do, is we want to have a measure of speech that gives me some prediction of how a person's functioning in their environment. If I had to, that's how I would articulate the purpose of this test as a clinical audiologist. I want to have a measure, because we said, speech is really important. It's the most important thing that we listen to. It's the basis of communication. It's the basis of, people's complaints. It's the basis of people in their families not liking them because they're not understanding speech. So all of these things go back to speech. So it's important, I think, to try to assess how a person does with speech. And so therefore it would be nice to have a set of speech materials that were in fact representative of typical speech. And I could argue for you, I think you believe me on this, I could spend a couple hours just arguing about the nature of and the flaws in these word lists and why they're not representative. Phonemic balance. Let's just think about that. So what does phonemic balance sort of imply to you as a goal in a test? As a goal in this kind of test, what does phonemic balance say to you?
Both syllables in the two-syllable word have equal amounts of energy.
We're really not talking about the energy. We're talking about now the construction of the word materials themselves. So what words are we actually saying? What are the speech materials we're actually saying? How could we ensure that a test that I'm doing has phonemic balance? Or as you do these tests, what is it that you're thinking? Because maybe you're not even thinking about it at this point. You're just saying a bunch of words on a piece of paper. Or you're just, so you're not really caring about it. And so I hate to disrupt your.
Is it with the vowel placement?
No.
Is that making sure that, I guess for a CVC word, you wouldn't want the last consonant to have a significantly higher frequency than the first consonant?
It's not okay. Again, it's not necessarily on a token by token basis. So if I had, if I said, you know what, we're gonna do a Cal State LA word list here, and it's gonna be phonemically balanced. Here's my word list: dog, door, down, doofus, dinghy. That's my word list, and you're gonna say, and that's phonemically balanced. Is that a phonemically balanced list? Why not?
It doesn't include all of the phonemes.
Yeah, it doesn't. It seems like there's an overload of one of the phonemic elements. Okay. Number two, I don't know what. I wasn't thinking about any other objections, but certainly it doesn't have likely, it's an unbalanced list, so you recognize at least it's unbalanced. So to get to balance, what would we have to do? We would have to create a list of words in which, now we're looking at the CVCs that are included in all the words, that have basically are representative of their frequency of occurrence of those sounds in the language as it's spoken. Well, how do you do that? You know, there are some estimates, there are some studies that have been shown by like linguists of most frequently occurring words used in conversation, most frequently occurred words used in telephone conversations, most frequently occurring words in print. Now, this is going to be an odd concept for you, because this goes back to a concept called the newspaper, which you're not really aware of. But way back when, news was gotten from actually ink on big sheets of paper. And the sheets of paper are so big you could do other things with them when you're done. You could wrap fish with them, you could do wallpaper repair, you could do lots of stuff. And so that's the way that came out. It came out once, twice a day, and you had to go buy it at stands and things like that. The first basis of this kind of representative stuff was somebody did a word count of the most frequently used words in print in newspapers in like 1924. They culled those words, and believe it or not, that led ultimately to the CID W22 and to this. So the most frequently occurring words that are used on these word lists actually originally derived from words in print in the 1920s. So guess what vocabulary changed? Honest to God, on the W22, this was a word that's on there, vamp. It's like, whoa, really? Vamp? Because it was a popular word in 1920 and the 1920s. And there was other words like that were in popular use that sort of had to get cleaned up. I don't think that, vamp would not have made it to the NU6 because it's got a double consonant ending. So anyway, so the whole notion of phonemic balance would be we would have to acquire some frequency occurrence of the sounds in the language. That's part of it. And ensure that we have the right number of them in the word list. But more than that, we have to ensure that the sounds that we have in the language also represent their degree of importance. Because it's like, okay, you know, there's going to be more sounds that are going to be contributing to those. And so if that's the case, if the S sound and the SH and the F sound are much more important in understanding language than is the D sound, by a ratio of 3 to 1 in terms of the S sound is 3 times more important than the D sound, then the word list that we create should have 3 times as many opportunities to hear the S sound as the D sound. Is that present in the phonemic balance test that you will use as a clinician? No, it's not. And that's one of my objections to this notion of phonemic balance. It gets me crazy, because it's not going to be, and it's not representative of typical speech, because it's monosyllabic, and so there's some issues with that. So I just want you to understand it, that whatever people think about these word lists, they're really not phonemically balanced. They don't represent, the word lists don't represent this, which is to say we don't measure the sounds that are really the most important in speech. Now, by the way, some people have adapted word lists, and you will find, and I'm not sure if, I'm sure I have a source for you, and probably Margaret does too, but people have created high frequency. Now in this case, high frequency, we're talking about the energy, not the frequency of occurrence. High frequency word lists. High frequency word lists, yeah. And so this would be really useful, for example, in doing hearing aid work. Because if most people have high frequency hearing loss, it'd be more useful to see whether or not a hearing aid provides them with additional audibility for those sounds. And so it's a list of words that are all built around, with a common vowel, like the I vowel. Like, so it would be like fish, fits, fix, stick, and so on. So the vowel is pretty much uniform in all these, but you're varying, the beginning and ending. And since most of the sounds that are most difficult for people with hearing loss to hear are going to be those voiceless fricative sounds, voiceless stop sounds. So the P, T, K, S, S, H, F sounds. So you have like word lists like that. And so again, I guarantee you that someone who has that high frequency hearing loss, they'll hear something. They'll hear the vowel all the time correctly. I used to do a thing with somebody if I was trying to, I got the test and everything done, and now I'm counseling them to try to move them to make a decision for hearing aids. And so I came up, I just did the same thing. And there's a couple more. So I would come up with this, and I'd say to the person in counseling, I would say to them, so if someone has the most typical loss that you're going to see, something like that, or something like that maybe, where here's 2K there. So they're pretty good, 1, 2, like 500, 1,000, but here's 2, here's 4. Okay, so when you look at that and you infer or you draw, the ideal thing would be is that you have an audiogram that's got speech spectrum on it. You draw their audiogram on it, and now you have a basic. You already know this because this is now hardwired into your heads. Okay, you got this in your head, and so you know what audibility, what's available to them. Again, remember this is where the level of this ellipsis is roughly at about a 45 dB HL average long-term speech spectrum. That converts from an SPL, is about 20 dB conversion for speech. So this would be given as 65 dB SPL. So when you're looking at the Verifit that we have, and their speech signal, sort of normal speech signal will be like at 65, and it can go up or down around that. But that's what this is supposed to be, long-term average speech spectrum around 45 dB SL. So I would say to the person, I say, yeah, you've got a problem not picking up some of the high frequency sounds. And the demonstration that I would do is I'd do this. I'm going to say some words to you, and I just want you to repeat them back to me. Okay? And here's the words I'm going to say. I'm going to say thin, fin, sin, pin, tin, kin, that sort of thing. And I say, okay, now stand back to me. Say the word thin. Say the word fin. So as soon as I deprive them of the visual cue, what happens? What do they hear? What does that person hear and is able, so face to face, I'm going to say, thin, fin, pin, and say, okay, yeah, easy test. Should be not a problem, because I'm in denial, and I'm not going to, I got this, I'll be able to do this. Easy, okay, because I'm hearing you easy. And that's what we'll say, that's what this guy's going to say to you. He says, hey, Dr. Ivory, I don't need hearing aids, I can hear you, we're talking back and forth. How many times have you had that conversation, Lane? Like every day, right? That's what they do. Yeah. So here's one way, and this works really good if you've got a significant other there that can see what you're doing. And so you just say, okay, here's what we're going to do. Okay, say the word thin. What do they hear? Someone without hearing loss, what do they hear? Unaided. In. Say the word fin. What do they hear? In. So they say, all they're saying is in. But the person over here, is hearing and seeing and knowing what I'm doing. And you can just see it on their face like, oh my God, that's the problem. There it is. There we've exposed exactly what it is for this person, and that's exactly my problem. And so then I'll go say the word thin, and he says in. I go, say the word thin, and he goes thin. I go, say the word pin, nothing, say the word pin. And it's like, boom, he gets them all the time. And most of the time, after you go through a couple of the words, that just crushes it. There's like no walking back from it, okay? However, I had one guy who was arguing that I was changing the test up so that I was goofing it up. And he was really mad. I've never seen a guy get so mad at me in counseling on doing this routine, which I did daily, multiple times a day. But this one guy just got really angry with me. And he accused me of saying a word like, he must have said, okay, say the word, what did I say? That kind of stuff, so... And it was like time to go, and I said, okay, well, you think about it. He just sat in his chair, just arguing with me. I don't know, I didn't have to call security or anything, but it was like the weirdest sort of, not the weirdest, but the most extreme form of denial I'd actually seen, that he actually took to arguing with me that I was, I was gonna say, dude, I work for Kaiser. We don't sell hearing aids. I got no dog in this fight. Mister. It's just so like, what do I care? I don't ever say that. I don't care what, you never want to say that. Of course we care about all our patients. But, because we don't want that reported back to the patient. Dr. Ivory was rude and said he didn't care about me as a patient. No. We care about you very much. Get out. I have to go. It's like clock, a variety of things. So, but anyway, it all gets down to these being the sounds that are going to be most important in their life, fundamentally, with that kind of hearing loss. And again, how many samples of these sounds are present on your NU6 list? Not many. So sometimes, again, for special applications, you're going to need to create your own materials, particularly kind of for counseling. We know that these have this gradual growth function, which we can say correlates to sital lesion. You already looked at the last class. We did what the PBPI function looked like for conductive. It's just shifted over. We looked for sensory neural. It's never going to hit that 100% asymptote. We looked at what it would be for retrocochlear, which would be that rollover function. And again, the only way that you're ever going to have a sense of whether or not you're hitting that is if you were to do multiple presentation levels, which you probably will rarely do. Why? Time. So again, at some point, with the asymmetrical hearing loss, sensory neural is probably when you want to do multiple presentation levels, one at the level that you think is a good level and one at a higher level, just to see what happens. PB max, we just said that's kind of a common phrase. Measured and reported in percent correct. Their response is a repetition of a word. And again, the words are not familiarized, but assumed to be in the person's vocabulary. So here's some problems with this, and I think you've read this. I jumped a slide after Olson and Madkin, and so these are just sort of a set of factors. And again, much of these we've sort of talked about a little bit. The notion of this is really phonemically balanced. Are you using 50 words or 25 words? If in a 50-word list, which these word lists were originally written as 50 words, and then they were just divided in half. Well, what happens is this, if the 50 words were phonemically balanced, how do we know if the 25 version truncation those are phonemically balanced also? So that was a complication. Do you use a carrier phrase? Do you have background competition? What test materials are you using? Again, scoring and error analysis. So most people score it on a whole word basis. So again, I want you to think about it on, even though you're probably going to report it on a whole word basis, I think as a informed clinician, you really got to think about what are the errors that they're making, and understand that a person with a high frequency loss is going to miss high frequency sounds. They shouldn't be missing low frequency sounds, and if they are, then something else is going on. But the most critical variable here, the most critical factor is presentation level, because if it's not audible, they're not going to be able to hear it, plain and simple. So let me go back one slide and just see if there's anything that I missed. Outcomes heavily dependent on audibility. Presentation level is critical. Factors, most important factors, presentation level. Are you getting a theme here? Are you getting a sense of something that's kind of important, that's under your control? Presentation level. Outcome is influenced by audiometric configuration. These materials don't really represent typical speech. And then these last two ones are also tricky once you're in a clinical environment. We don't really have a sense of what's a significant difference. That's point 6 here. So one of the things you're going to want to look at is you test the left ear, right ear, and you get one score in the left ear, one score in the right ear, and they're different. You want to say, are they clinically significantly different? How much difference has to exist between these two scores? Same thing said if you're talking about the same. If you're talking about just an individual score, how poor does it have to be in order for us to say that's a really poor score? And so again, we're left with the same problem here as we have with talking about degree of hearing loss. What are the words that we're going to use to describe a number? So they're all over the place. So what's excellent, good, fair, poor, that sort of thing. So you can look at your book to have a sense about what those are, and have a generally said, most people are going to say, since we're doing whole words scoring, then each word is worth 4% on a 25-word list. So 92 to 100 means they missed 1 or 2 words, or none. So 92, they missed 2 words. 96, they missed 1 word, and then 100% they got all of them. So we would say that's probably excellent. Then probably like 80 to, 80 to, at this point, it's just whatever your clinic is agreeing to utilize. But there's basically, it's just going to bring it down by probably 10 to 12, probably 12% differences go down each level. That's a reasonable way to think about it on that 12%. So that 12% reflects a 3-word difference, And I would bet you that most of your clinicians that you're going to work with, your preceptors are going to work with, will probably say 12% or more difference is going to be a significant difference. Now, is it really? For a practice clinician under really good circumstances, and the words, on the word list were delivered at an audible level. 12% is a reasonable number. A lot of clinicians and a lot of sort of the scientists in speech perception say that no, that the 12% really isn't a clinically significant difference. And so there's a couple of ways that we can kind of go about figuring that out a little bit better. But again, in the time that we have right now, maybe by the end of the course, there's some other material I have for you can look at. But I think the basic message for you right now is you need to understand what is it that your preceptors are thinking is a clinically significant difference, and it's usually 12% or so. There was a lot of I don't say noise, but there's one of the things that's kind of influenced people's thinking about this is something called a binomial distribution. And it was done by two guys, you'll see their names in the literature, Thornton and Raffin. Aaron Thornton, Michael Raffin. And what they said was that our whole view of looking at clinical significant differences is flawed, and because we're applying the wrong underlying statistical model. So it's like a lot of math and stuff underneath this that most clinicians don't really care too much about. And that's probably why it got such acceptance, because the clinicians really, the audiologists didn't really have the capacity to understand that it was really, to me, unfounded. But everybody just kind of had to go with it because it was so compelling in terms of the math. But what they're basically saying is by calling this binomial, what that means is that for each word, this is their assumption under binomial distribution, that each word has two outcomes, incorrect or correct. And so therefore, if you apply that way of scoring, just it's either correct or incorrect, now you have to go to a binomial distribution table, which would suggest for a 25-item presentation that the difference between ears would have to be some ridiculous number like 44% or something like that. I mean, it really kind of, now whether that's true or not, we don't know, exactly. But that was their mathematical assertion. I doubted that anybody really does this, but I want you to be aware of it. You probably may see something on Praxis on this. Now, the reason that I never really bought into this at all, and by the way, Raffin's a guy that's around, he's a Southern California guy, I think. He's been around here a lot. He taught, when I was at CSUN in the 90s, Raffin was teaching some other class in the master's program. I forget what he was teaching, but he was, how can I say this? I shouldn't say anything like that. I'll just leave it at that. And actually, Margaret might know him. So, I'll ask her when I get out of class, did you have any intersections with Mike Raffin? And I don't even know whatever even happened to him. But anyway, I have met him on a couple occasions, over at CSUN. Why would I have the naive and mathematically unsophisticated sense that a binomial distribution or assumption that the outcome here is either correct or incorrect, that's the basis of it? So say the word thin, the person says tin. Yeah. Say the word thin and they say sin. Because most likely people are gonna make an error within the class of the sound. So if they're gonna make, again, hearing loss skews frequency. And so when you're thinking about, about manner of production and so on, they're gonna be sort of they're gonna make an error across sounds that are produced the same way, but are produced at a different location in the mouth, which is a different frequency, because they're going to goof up on the frequency. But they're probably not going to confuse as much a stop with a fricative sound. But anyway, I digress even further. So why is a binomial assumption potentially flawed.
Because it could be getting most of the work.
Yeah, because I don't see this as an absolutist right or wrong. In fact, I'm on the total other side of, this, of the thought process here, which is they're hearing multiple phonemic phonetic units, and if they get some of them, they're partially right. So even every error, even every whole word error, the person is partially correct, I would bet. There's going to be very few cases where the person's not going to be able to get the vowel stuff correct. There will be some. And there will be some that people are not going to have any audible sensations and things like that. So there's going to be a group of people that are not going to be able to respond to these sounds. But the fact of the matter is, if you have someone that has any audibility into their cochlea and any sort of neural function, they're going to be hearing something, and they're going to hear usually the elements that are the highest amplitude, which will always be the vowel sounds. So there you go. All right, so I don't want you to get too crazy with all that stuff. Just the last thing here, Ted Bell, who was on our campus here for some years, had worked with Don Dirks at UCLA for many years, and beloved Richard Wilson actually collaborated on a project that was done on our campus, the norming of this. And so I think I gave you the Bell and Wilson article, and I thought this was a brilliant article, and it was something they did on contract to do for the VA as a better test for the VA, because the VA uses NU6 word list as part of the compensation pension arrangement to get a compensable hearing loss. So they're the ones that were kind of fueling it. And so Ted took these elements that we were talking about here, which are looking at how often a word is used and how phonetically similar it is to other words, and so has ideas of high use, low use, and whether they're unique, and calls that sparse and dense. And this was all based on a model of cortical activation called the net neighborhood activation model, so big in linguistics. So that's where most of this sort of came from. And so he ended up creating a list of words that could have could be characterized as one of these four potential corners. So either sparse or dense, and either high use or low use, and you just combine this 2x2 table. And so then he came up with, by looking at sort of appropriate materials of frequency occurrence of words in the language, he came up with words and put them into sentence structures, in which the sentences themselves don't really cue much meaning. So remember we talked about it in sentences, you have more information to gather. And so the information here is more or less neutral, was the goal. And so they're scoring on a couple of words. The words that are italicized here would be the ones that would be scored. And so you see then the frequency occurrence and the density value. So in other words, there's going to be words that have a lot of other words just like them, and therefore they're going to be more likely to be uttered. And it's the words that are phonemically sparse will be a much more different probability. And they did this for older and younger individuals. Let me just see if I got that right. No, this was all individuals in quiet. Sorry, that was another study. Where we're just looking at how do these word lists work as a function of signal to noise ratio, where there was no signal and they started adding noise into that. And again, what were the poorest, let's say, what were the best scores? Words that have a high frequency occurrence and have very few other words like them. So those words, were uniformly better at all signal to noise ratios. And again, the words that were the poorest heard were ones that were had a low frequency occurrence in the language and were phonemically dense. There were many other words that could be there. So again, I'm sad that this never took off, because it would have been we would get a lot of information, and it was really founded on really strong principles. And again, there's just and also there's some nice words that are in the word list. And it was done at Cal State LA, so it was like great up to a point. All right, so I'm going to move on to tympanometry. The slides that I think obviously are kind of important for you as far as word recognition. Are these slides on what it is and what the problems are and what the factors are. And again, this factors one. You're in control of mode of presentation, carrier phrase, presentation level, and how you score it. So those are the things that are on you. Those are the things that you'll just have to kind of follow what the convention is at the clinics that you're going to be working at, and just get a sense of how they do it and what they do. Again, some of the things that I think are really good practices that you just may have to tuck away right now, you might find much more useful when you're, in maybe a practice where you're fitting hearing aids more, where you're really interested in frequency selectivity and audibility of high frequency elements, and that's what you're trying to have additional data. In other words, another way of saying that is if we had that person with a high frequency hearing loss and we wanted to do a test, in fact, who did this? The original person that did this. The original hearing aid evaluation procedure was done by, if you had to throw out a name, Carhart. So Carhart in the 1940s was basically put in charge of establishing oral rehab programs for returning service personnel from World War II. And they set up oral rehab centers at different places in the country. So Carhart, the hearing aid one of the elements of the hearing aid evaluation was that individuals listened and repeated back whatever the monosyllabic word list they were using at the time. It might have been the W22, might have been the list before that, which was the Harvard Psychoacoustic Lab list. So Harvard Psychoacoustic Lab was called PAL, P-A-L. So the PAL 50 or the Egan 50, Egan was the guy there. Read those to the person with hearing aid 1 and get a score for a word list of 25 words, and then hearing aid 2 and then hearing aid 3, and then would select the hearing aid that had the best word recognition score. That's how Carhart said to do it. So what's the real problem with people who have high frequency hearing losses and that particular approach? It's not that Carhart gets a lot of criticism for this. It was probably as good a thing as any to do at the time. This is before we had probe tube microphone measurements and any of that kind of stuff. So what's the problem? What's problem number one? If you have hearing aid, you have 3 different hearing aids and you read them each, the person has hearing aid 1, hearing aid 2, hearing aid 3, and you get this percent correct score, percent correct, for number 1, percent correct for number 2, percent correct for number 3, and you have to make a selection and you're issuing a hearing aid to that person. What's the problem with that? How confident are you that you're making a good decision? How likely that this is an insensitive test? These are not necessarily rhetorical questions. You can attempt to answer them, and I won't be offended.
Well, how are we presenting them? Was it already just sort of
Presented in sound field at conversational speech, so typically the test will be done at 45 dBHL, where you're delivering the words out of a loudspeaker, because they have to be hearing through their hearing aid. So you'd get a baseline score, 45 dBHL for a list of words, and then now you put hearing aid 1, hearing aid 2, hearing aid 3, and you do the same thing, you just keep repeating words to them.
Well, they could all be similar scores.
The scores could be the same, and so what if the scores are the same, then how do you make a decision? Okay, that's very good. And then again, if we're saying that you have to make a decision, what's your decision based on?
the percent?
The percent correct amongst the scores. So we get back to that one of the questions that I raised, which is how significantly different does it have to be? The delta is usually a different sign. So how different does it have to be in order for you to say, you know what, I'm gonna fit you with hearing aid number 3 because this one we have a 16% difference compared to hearing aid 1. Or we've got a 20% difference. You heard 20% better with hearing aid number 3 than you did with these other 2. Would you feel confident about that? Yeah, maybe. Yeah, what I said, 12% may be significant difference. Would Thornton and Raffin be happy with that? No, absolutely not. And so, so when you've got a big enough difference, and so then the question is, well, then what is a big enough difference? But it also would depend on, person with a high frequency hearing loss, were the words on 1, 2, and 3 give them an equal opportunity to hear the high frequency sounds that is most troubling to them, or is is least audible to them, and you don't know. You'd have to, and the clinicians back then didn't do a spectrographic analysis of all the words to kind of come up with, with that, but there was still an understanding that this was not a good test. This was not a good way to do it. And and how do I say it? If it was, that's all we would be doing. We would have never advanced the field of hearing aid evaluation and fitting beyond this. If this was good and that was it, then that's what we would do. But we didn't. So again, it gets down to that significant difference. So if one of them is, there's an 8% difference, and a 4% difference, and a 12% difference, what are you going to choose? Do you think there's any significant differences across the three of them? Maybe between one and, across the three of them, you don't have I guess we need to compare 12%, I guess, one or the other. So sorry, I'm confounding the numbers here a little bit. But you get the point, is that if you only have an 8% difference, are you going to say, what do you choose? You got to choose something else to make a decision about. All right, good. We'll revisit some of this stuff, and a lot of this stuff are things that you're going to be putting into play, into practice. But again, the principal one for you is going to be presentation level. And again, presentation level is an issue primarily for sloping hearing loss. If you have a flat hearing loss, the threshold of 2K is going to be the same as your SRT. However, in a sloping hearing loss, your SRT is going to be way under, because you got to figure your SRT, your 2-frequency pure tone average in a sloping hearing loss is going to be based on 500 and 1,000 hertz. And therefore, when you go 40 dB above that, so the usual rule for presentation level in most clinicians, and if you come up with this, I don't know how to tell you to handle it diplomatically, is it's always going to be 40 dB above the SRT. And if that's a hard fixed rule, that's going to be tricky because you're going to underestimate the PB max on sloping losses. Guaranteed. I mean, it's not a question in my mind. If I'm criticizing an audiogram, I'm called to review an audiogram, that's the first thing I'm looking at. In terms of the word recognition score, look at audibility, and if it's a poor word recognition score, it's like, that audibility should be better. And why is that important to know, by the way? If it's bilateral and it's symmetrical, what difference does it matter if an ear with a sloping loss has a 64 or a 68 or a 72% score in each ear? How does that affect anything that's important in what you do as an audiologist?
Does it determine the benefit of hearing aid?
Well, yeah, because if this, it's going to determine, and Natalie said it's going to determine the benefit of hearing aids. It's going to determine certainly your approach to the patient about counseling them relative to, wow, your word recognition score is 48%. That's really, really bad. I don't think hearing aids are going to help you. Bye. Or your word recognition score is 64%, whatever the number is. But if it's really, if you got a score of 48 here or a 64, but it was a presentation level issue, then you don't have a valid finding. And so what if then you kick it up another 15 dB and that 64% now goes to 84%, and that's their PB max? Is there going to be a difference in a person whose word recognition score is 64 versus 84 and how you approach them? Yeah, probably so. And if that's the case, you can be more confident in what you're going to be suggesting the benefits of hearing aid amplification of. I would never say you're going to hear, a person's going to say, I can't hear and understand speech, particularly in background noise. And I would never say to you, oh yeah, well, this hearing aid's going to, fill that in completely and you're going to be able to hear everything that's being said to you. Don't do that. Or do it once and see what happens, and you're going to have a lot of grief. And then that's going to be a patient that's going to be mad at you for the rest of their life, and will be telling their friends all about you and that you said something that was not true. So my very conservative way of approaching this is to always sort of provide an under expectation of what the benefits are. And if it turns, and the risk with that is, so the person with a 48% word recognition, let's say I did multiple presentation levels and it's a pretty solid 48%. So that's suggesting that under ideal conditions in quiet for monosyllabic words, that they have difficulty in extracting enough information to get those words correct. Now, does that translate into that's going to be their word recognition ability, meaning their ability to converse out in the environment with their families?
No.
And so what's going to be better? It's going to be better or worse?
It's better.
It's going to be better. Why?
Because it's in silent.
Well, in the background of, if you look at that spectrum I had of, analytic to synthetic, that if you're talking in familiar circumstances on a known topic, and the context of everything is known, that person's going to have an ease of conversing and being a good communicator, but not because they're extracting phonemic elements, but because they're extracting other elements from the context, from the topic. There may be words that they're not hearing at all, but they'll be able to be a fluent and competent communicator because they're filling it in. Remember, hearing loss is a loss of information. And if you can put that information back some other way, visually, say the word thin, or you can put it back topically, I went to the lake and I caught a fish. Okay. You know that you're at the lake, you know what it is, I went to the lake and I caught a fish. What? They're not going to get that wrong. Even if it was a purely, a poorly encoded signal on that last word. They filled in the information. So 48% is that necessary, but still for me that still is kind of a red flag, and so I'm going to say, well, you may not be able to hear all the sounds that you'd like to hear all the time. You're not going to be able to hear exactly in background noise as you once did, but you'll hear better. And you got a trial period, so go ahead and try it, and it ultimately is up to you. As opposed to saying, you're going to hear everything you're going to hear so much, no, I'm not going to do that. So the risk is by sort of under promoting the potential benefits, the person might say, you know what, Dr. Ivey, you're right, I'm not going to get hearing aids right now. If you can't promise me that I'm going to hear everything that I want to hear, then I'm not really interested. So that's the problem. And you got to be able to live with that, I guess. Because otherwise the person's going to be, you have to get their expectations correct. And I think their expectations more or less ride their word recognition score. So I'm not saying it's like a perfect measure, but I'm saying it's informative. In the sense that if it's really, really poor, then I know that their phonemic extraction ability is really poor, and they're going to have to depend on other things. And again, what's going to happen with older adults? As they get more cognitively impaired, as we all do, as we all are, getting cognitively impaired, then they're going to have less capacity and less flexibility to draw on those other sources of information. And so again, we also have the notion that cognitive impairment is advanced in cases of lack of input to the auditory system. So there's all kinds of studies done, thankfully not by audiologists. The audiologists were participants in it, but studies done at Johns Hopkins by Frank Lin, sort of in gerontology and sort of long-term studies that showed that people who weren't wearing hearing aids had poorer auditory abilities over time. Ones that had hearing aids, their abilities were much better. So there is a kind of a use it or lose it sort of notion. All right. Well, I didn't get to tympanometry, but I want to do something real quick with you. And to do this, I'm going to go to the camera.
I have to show you, it's complicated.
Yeah.
Okay, so I have for you a slide set that's called Tympanometry Part 1. So it's available to you now. I don't recall that I have a tympanometry part 2. So I don't know what I was thinking, but so just, again, keep your expectations down. If you're expecting part 2, I'm telling you right now, you're not going to get it. At least, because I don't know where it is. I don't know why I did that, but you have that. And so what I'd like you to do is run through looking at it. What I'd like you to try to do, if you can, and I'm not sure that you can, but if you read through this material. The other thing that I provided for you was something that's called tympanometric case studies. And these tympanometric case studies, it looks like this. So there's 14 of these. And all the answers are there. But here's how I'd like you to approach these, if you would. Because you can use this as kind of a program learning sort of thing. So what you should probably do is kind of block this out. And so you're looking at just the data there. You're looking at the audiogram, a little case history information, and now you're looking at some of the data that are available from a typical tympanometric measurement, all right? And so the only thing you really kind of have to know here is, to kind of walk through this, is sort of what the norms are, kind of, okay? So if you want the norms for ear canal volume in an adult, 1.5 is a pretty good number. So 0.75 to like whatever to like 1.9 or something like that. So this is in milliliters of volume. So this is the volume of the ear canal. And again, this is something that when you press that button and all the tests are engaged, these are the data that you're going to get. They're all important. You're going to get the location of the pressure peak. So on the tympanogram, you're going to see a peak somewhere. In many cases, on a normal tympanogram, you'll see a peak. And what this, in this little set of tympanograms, pressure peak, which we're going to eventually call tympanometric pressure peak. That's the standard name for it, is TPP. So TPP is tympanometric pressure peak, is really the location of the peak if you got one, and sometimes you don't. And so the machine does this for you. Our machines do. Will give you that value. So when you get that strip chart recording, or you're looking at what's ever on the LED that on the screen, it'll give you these numbers. And again, this is in units of decapascals. So DAPA. And so what that really means is, that means that that's the value of the pressure here. Remember, pascals is a unit of pressure. In the old units of measurement, it was dynes per square centimeter. So in your acoustics class, whatever you had, in the acoustics classes that I had my hands on, we talk about it not in terms of pascals, which is the normal scientific way to do it in modern times, but in dynes per square centimeter, because we can figure it out through the calculations easier. So that's this value here. That's this axis, where 0 is interpreted to be, 0 DAPA is interpreted to be ambient room pressure, not necessarily the ambient pressure of the environment where you are, because that number on an absolute basis will change depending on where you are in terms of altitude. So, but we don't care about that, because we're not going to do a test here and then all of a sudden go and do the same test in Denver. Okay, we're going to go from here to a mile high. We're not going to do that. Okay, but that's what that is. And so again, the pressure peak should be, probably no poorer than minus 75 DAPA, and you're going to rarely see anything that's a positive number. So we have 0 positives and negatives, and given that, the last two values is shown here as static admittance, and it's shown with these symbols Y subscript TM, YTM. You might also see this as SAA, a different SAA, I should say, static acoustic admittance. And that's the value of the other axis. And we'll talk more about it as we go through. Over the 30 or 40 years that I've been looking at tympanograms, as different levels of instrumentation have come along, and even actual different instruments that do these basic measurements, the labels and of this axis have changed. But one of the great saving, wonderful things that's occurred is that even though the instrumentation, the actual devices you use, have changed, and the actual underlying measurements and the metrics that people are using over here have changed, the data that we get are still very useful. And so, for example, initially, so the axis you're looking at is that one, which is in units of volume, milliliters. I saw there was actually units of water pressure at one point, and in the early use of admittance, one of the other things that was done was to use, if you're familiar with the value of ohms, ohms is a unit of electrical resistance, and so admittance is the mathematical converse of, or inverse converse, of admittance and impedance. So ohms is a unit of impedance, and so this is the opposition to the flow of energy. Admittance, as the word might suggest, is the ease of the flow of energy. So these two things are related. They're both measuring energy, but it's just like you're measuring how much is going in or how much the system is opposing it. So one of the other units of measurement that we had at one point in time was based on that, and they were called milli. And so what's this? This is ohm spelled backwards. That's how goofy this was. And so I never knew how to pronounce it, so I always said mummy hose. And I'm not sure whether that played very well. But in the spirit of Thanksgiving, I just wanted to share that with you, that we had mummy hose was really part of what we did. So with that, I'll see you back next week. Oh yeah. So and gradient is just basically the distance across this, and gradient is a number to come up with the whether this is a sharp peak or what's the spread on either side around the peak. So what I want you to do is look through these 14 cases, block out the information, and see if you can work through them and look at it and understand. This first case, I think, is a normal, so that gives you kind of a normal sense of stuff. And so again, we'll kind of plug some other stuff in. So some stuff gets uncomfortable, you're not sure what you're doing. We'll go through them all on next Tuesday. But give it a shot, give it a try, and I think it'll be a good way to kind of